Mel's on the move.
Yeah. Mel was on the move.
Thank you very much. I'd like to call the regular meeting of the Thompson Regional Hospital District for this, the 13th day of June 2022 to order. We are honored to be able to hold this meeting on the ancestral and unceded lands of the Tecumlebs Teshekweppem in Secwepemc Ulu. The agenda is before you. Are there any additions or deletions from the agenda? A motion to approve the agenda is in order. Moved by Director Stamer, seconded by Director Swan. Discussion. Director Quinn.
Mr. Chairman, I think today is the 16th, not the 13th.
Yeah, that's correct. Thank you. I'm still on Monday. I'll call the question on the agenda as circulated. All of those in favor, those opposed, that is carried. Thank you. You have before you the minutes of the meeting of the Thompson Regional Hospital District on March the 24th, 2022. How say you? Moved by Director Gillis and seconded by Director Kershaw. Were there any errors or omissions? Seeing none, I'll call the question. All of those in favor, those opposed, that is carried. Thank you. So it's my pleasure now to invite the new and resident Vice President of Interior Health, Diane Shendrick, to the podium. And first of all, we want to welcome you. We are the Regional Hospital District for this region, and we encompass everything from the Scotch Creek area in the Columbia-Shuswap Regional District through to Goldbridge and Braylorne in the Squamish-Lillooet Regional District. All of the TNRD is included as well. And so we're your biggest audience for Royal Inland Hospital and all of the other regional facilities around here. And while I'm on that topic, we have a few directors that are busy today with another event that will be coming in shortly. But I'm interested who is, it's Merlin Blackwell is on the phone due to a highway closure, I take it. And we have Ian Wood and we have Director Dale Bass on the Zoom today. So the rest of us are all identified by our name tag. So welcome, Diane, the floor is yours.
Oh, good morning. And it's my pleasure to be here and to join you this morning. I do call Kamloops home. I moved to Kamloops in January of this year and moved into the Vice President of the Clinical Operational North portfolio in October. So it is my pleasure to be here and particularly to be here in person. And I certainly have had the pleasure to meet a few of you over time, but not all. So today we thought just would give a general overview. I'm really pleased to have Ian Wood join us, who's online. And also I have with me Michaela Swan, who is just announced today our Director of Communications for the North portfolio. So really pleased to be able to share that today. And of course, I think she knows so many of you. We also have Todd Mastel, our Director of Finance, who is joining us with Corey Ween. And Tracy Rani is off this week on a well-deserved week holiday. So pleased to have Jerry Delettis join us as well from Royal Inland Hospital. There we go. Thank you. Also, a territorial acknowledgement within Interior Health. We do recognize and that we collectively gather on the traditional, ancestral, and unceded territories of 7 Interior Region First Nations, and it is also home to 15 chartered Métis communities. And it is with humility that we do continue to strengthen our relationships with First Nation, Métis, and Inuit peoples across the interior. And certainly, as Ken has already introduced today, meeting on the Secwepemc Nation. We jumped ahead there. Where we need to. So our clinical operational portfolio oversees leadership for the provision of acute, community, long-term care, mental health and substance use, public health, primary care operations, along with allied health services. Clinical operations in IH North provides operational leadership with the following geographic regions: IH West, North Okanagan, and East Kootenay. So we actually go up and then do that circle around. In addition to the operational leadership within these geographical areas, this portfolio leads IH-wide clinical programs and networks that include critical care, emergency and trauma services, maternal and child health, renal services, surgical services, and our professional practice office and chief nursing office, and also have direct responsibility for our surgical strategy, which is one of our strategic priorities within Interior Health. The overarching vision that I and my team have is sustainability of services and taking care of people. And taking care of people is a priority, both people that access services, our communities, and people that work within Interior Health, as well as our contracted partners. Next, I will provide an update on your district, and this is just an introductory slide of which each of you are very familiar with. This is our key Interior Health rural contracts. I hope that many of you have met each of the managers that oversee each of these areas. We also within rural have Karen Cooper, who's the Director of Chase and Kamloops Outreach Services, and Ian Wood, who has joined us today, is a director for all the other communities in rural, and certainly Royal Inland is underneath Tracy Rennie and her team, and Dr. Todd Ring, who's the medical lead. In regards to a rural service update, and I recognize that many of you have this information, but just in regards to an update, in Lillooet, IH is the owner and we operate the primary care clinic, and we have done so since August of 2021. This is an old building, as many of you know. We even have carpets on the walls and is in desperate need of work. So do want to recognize that. Within Merritt, at Nicola Valley Hospital, our inpatient unit, the rooms are very small. We have challenges with patients' equipment. Certainly bathrooms are an issue in accessing bathrooms, and a reno is required to ensure patient and staff safety. And in regards to our primary care networks, Interior Health has provided a rural expression of interest for PCM planning, and this was submitted at the end of 2021. We are waiting for approval of both the expression of interest and an early draw ask for our Aboriginal patient navigators, which are key roles, particularly in our rural areas. And Thompson expression of interest has been approved, and we are actively in planning phases for our primary care network for the Thompson. Reestablishing services in Lytton is a key priority for us, and I know for many of you as well. We do have primary care physicians 5 days a week, 6 hours a day. I do want to acknowledge that none of these physicians are living in Lytton, but they're very familiar with the community as they've all worked out of Lillooet and are very engaged and really have a desire to serve that community. Our local health planning table is being used as one of the mechanisms for community engagement, and community engagement and hearing from our communities is a top priority for us, and we want to continue to build those relationships. Dedicated engagement with our First Nations bands in and around the community of Lytton will have some targeted work this summer, and that work will be ongoing. In regards to our regional risk mitigations, fire and flood is top of mind, certainly has been throughout since last year and the unfortunate events that we have all lived through. We are always ongoing to learn from our experiences and to continue to prepare for any emergencies And there are always learnings. And also it is so important to hear from our community members as well as to what went well and where we can do better. I can assure you that tabletop exercises within health are very important so that we can work through, so that we have a good experience and we can learn from those. Those are underway. Our staff are completing updated training modules that have been updated from our experiences. And we really are focusing on ensuring our staff preparedness so that we have capacity to meet our organizational needs and our community needs. And an example of that is really just to have a family go bag when we need to pick up, support people so that we're ready to go and we can help inform that need. Again, I just really do want to emphasize that preparedness planning is really incorporating the lessons learned from last year's events. In regards to service delivery design, development of urgent and primary care centers in both Thompson and rural is top of mind. And there has been and will continue to be extensive engagement with local government, our Indigenous partners, and others. For the rural communities, the local health planning tables will be one mechanism for engagement. And those are Merritt, Lytton, Lillooet, Ashcroft, and Clearwater. And also really looking for those dedicated opportunities for Indigenous partners to be based within that location and within each community to be part of that planning as well. Very, very important. I will then now move towards our Kamloops Health Service Action Plan. RIH, Royal Inland Hospital, as everyone here knows, has been experiencing increased staffing and recruitment challenges. And this is a combination of factors that have led us to this point. People have chosen to retire as we've come out of the pandemic and decided where their priorities personally may be. We have people on temporary leaves for various reasons. Many other factors, including increased COVID-19 transmission, long COVID, and related staff sick calls as a result. Despite our best efforts to fill vacancies and recruit new staff, we continue to be challenged with our staffing vacancies. We have developed a 30, 60, 90-day action plan that will, and the key headings are up on the slide above you there. And it is to better help support our health services in the Kamloops region and really focus on the key drivers of the action plan, which will outline our key activities in order to be successful. The 30, 60, 90-day is a very tight action plan, but we believe the urgency is required. Additional focus areas that are included, which are sub-items to what you see to these main drivers, are tactics to address our critical staffing levels in the short term, as well as how we can support completion of specialty education for our specialty trained people so we can sustain those services. We did meet, Susan Brown came to meet with our staff, and Dr. Mike Hertel was in attendance with the physicians. Susan met with the nursing staff, I should be clear, and also the physicians. Dr. Mike Hertel was present with the physician group, who's our vice president of medical affairs. And with the nurses, I was present as well. And we certainly heard from our nursing staff and physicians some key priority areas that we were able to action quite quickly. And one area of an example, which may not seem to be very important, but for our staff was very important, was access to scrubs, where in our emergency department, our critical care and our COVID unit was a top priority for them. So we very quickly were able to support staff in that way. Additionally, we've had an opportunity where we've had registered psychiatric nurses who have come forward to say, we want to help in a different way. We already have registered psychiatric nurses working within our emergency department, which are highly valuable, but others came forward to say, how can we help? And they did ask for a skills assessment and training, which we were able to provide additional support to the emergency department. So the team is really very active in wanting to help support other areas and support the needs of the hospital and the broader community as well. So those are just a couple of examples that I did want to share with you today. We did also develop within Interior Health what we call an urgent response team. So this was a call out broadly throughout Interior Health in order to proactively manage and prepare for anticipated staff shortages. And I'm very pleased to say that this has resulted in 17 staff to be redeployed from other regions of Interior Health. And we currently have about just under 20 additional potential redeployments. And I'll just share an example with you of a note that I received from a nurse who works in Preston, actually, who had said, I would love to come to Kamloops, to Royal Inland to help. And she sent a note and said, thank you for the experience. She learned a lot. She felt that she added value to the care there, which I can absolutely say she did. And it was a very welcoming experience for her. And she did share that the team was great, was supportive, but also recognized we are very stretched with our with the limited staff we have, but did speak about that as well, but was grateful for the opportunity and said that she took back learnings, but also was able to bring forward and assist as well. This urgent response team allows an incentive for any staff that are 40 kilometers or greater. They do receive a 1.5 time pay incentive in order to respond. We also, of course, utilize agency nurses to augment our staffing levels. We have contracts with 7 agencies, and we have 41 agency staff that are currently scheduled to help support Royal Inland in May and June. And we also use agencies within our rural communities as well. Our process improvements to expedite our hiring efforts, improve efficiency, and enhance our candidate recruitment experience has been top of mind. And since September of 2021, pleased to share that 303 positions have been filled, and that's resulted in 60 net new care staff hired at the site. And we also have been very focused on supporting our new graduates and expediting their onboarding into permanent positions, and have hired 48 new grads just recently, and 43 of our student nurses are ready to start within June. So all highly valuable team members. Within the next 30 days, we are focusing on addressing key concerns that have been brought forward, as I said, by our staff in the feedback meetings that we did host. So focus on recruitment and retention, partnering with our staff to co-create action plans to improve our retention and workplace culture. We have reviewed and optimized, along with our staff and our union partners, the optimization of rotations for skill mix, full and part-time ratios, and schedule patterns. And most recently, 140 new positions were created, including 100 full-time and 40 part-time positions to provide that flexibility to staff. And that was a real important key element that we did hear from staff, was the need to have more availability for part-time positions versus full-time. So really wanted to optimize to meet their needs. We also are prioritizing our specialty education. We have 73 training slots that have been recently approved, with 17 filled and the remaining being actively recruited. I already did mention the 1.5 time incentive pay to support recruitment and retention of staff for those who travel 40 kilometers or greater. And currently we are working with our ministry colleagues around recruitment and retention incentives, and expect to have an announcement in that regard probably as early as next week. We also value our physician colleagues as well, and have put forward additional physician positions to help support the site in order to really help support patient needs as well. And we're looking forward to moving forward on those incentives. When we met with the staff, certainly, as everyone I think probably knows, advancing care electronically through our ACE project was rolled out within Royal Inland Hospital. And we did, myself, along with the VP of our digital health strategy, came to hear direct feedback from our frontline users, physicians, and staff, and are really looking to, at how we can optimize and improve those workflow improvements. When you transition to an electronic health record, it is a significant change process. So certainly that continued focus and work is really important. In regards to leadership, which is very important to support our frontline staff, certainly I am very pleased to be living in this wonderful community, and just want to share that I think together collectively, if we can share, because I certainly have really enjoyed my short time here, the how beautiful Kamloops area rural is. Together we can really try to recruit people to the area. So really look forward to your support in any way we can there. So I am located, my office is at Royal Inland Hospital, and I do have a presence. That said, as you can see through my portfolio, it's important that I also am in all those other areas as well. But I would say the majority of my time is at Royal Inland Hospital. And I've been very purposeful to engage in staff huddles, to go meet with the staff, and to really improve that communication directly to myself so I can support the teams to be successful. We do have increased medical director leadership presence at the site, who is there to help support our chief of staff, Dr. Trhd, and also our rural communities. And we are increasing our manager capacity to allow for improved staff engagement, retention, have that visibility, support our patients, really to focus on our key business functions, to hire and onboard our staff. And we have added, just recently posted for 2 additional clinical operational managers. And there has been interest in those positions. So those should be up and running very quickly. And also, I just announced very locally, it hasn't even gone that broadly, but we will have an executive director of Kamloops as well as an executive director for the Rural West portfolio. So we are going to have more support there to help support the work that we need to do. With Michaela joining us today with the team, a proactive communication strategy is really a key focus for us to increase our transparency, both internally and externally, and to really be able to proactively share the work with our key stakeholders. And again, this is a key component of our 60-90 days, because we did launch our 30 days, to also continue our focus on staff engagement and just continue to refine our action plan based on the outcomes of this work. Additionally, teams are currently initiating that early phase work. And a key component of that is conducting stay and exit interviews of our staff. And I certainly, I have one scheduled this week. I've invited people to contact myself directly. I'm open to hear from anyone to see what we can do, what would bring people back to Royal Inland and our rural communities. And our human resource team is also, will have a formal process in order to support stabilization of our services within Thompson-Nicola, that we can also reduce the burden on Royal Inland and continue to meet the needs of our rural communities and look at incentive options. In regards to the Gagliardi Tower, the tower is opening on July 17th, and we are pleased to be able to say that we will have an open house on June 25th. And I know I had the pleasure to tour the tower with many of you. Was it a month ago, I believe, about a month ago. It is a state-of-the-art facility that, along with sharing how beautiful our communities are, to work in such a gorgeous facility can be a real incentive as well.
I assume that was meant to read public open house rather than public house.
Oh, public open house. Thank you. Appreciate that. Thank you, Ken. This slide is really just a historical summary of the TRHD and IH co-funded projects that date back to 2013. And certainly with me joining recently, it was very good for me to review this information. One column represents the total committed project value, and the second column represents the RHD 40% contribution. Please note that we've rounded it to the nearest 1,000 and only represents projects that are co-funded. It does exclude investments funded through our IH Equity Foundations, donations, and targeted ministry funding. The 2022-23 values are lower as they include the MRI scope reduction, which offsets parts of the higher request in 2021-22. And the 2022-23 values also exclude the funding request for minor capital equipment, which is our minor capital is under 100,000, which hasn't been requested yet, as we typically request these, as you know, in fall of each year. So you can see the significant investments made in the region, particularly when I reviewed it from 2016 to 18 with large projects at Royal Inland Clinical Service Building and the Patient Care Tower. These are Thompson-Caribou Shuswap projects. At our Clearwater Hospital, certainly the domestic hot water system, which was 400,000 total, that project was completed. Our nurse call system, the amount is there in front of you, that was completed in September of 2021, and a renewable energy upgrade, which is about 2 million in total. But that work is still in progress with our expected completion in early 2023. In Lillooet, Lillooet Health Center and Hospital, our medical device reprocessing unit, which was about 700,000, that project is completed, as well as the biomass boiler retrofit, which that project too was completed. In Ashcroft Hospital and our healthcare center, our nurse call system project was completed in September of 2021. In Merit, investment of 6.4 million in total in the emergency department. Project has been completed. Our lab outpatient expansion, totaling 437,000, was completed September 21. And our fire sprinkler system at Gillis House project was complete as well. And in Chase, the general radiographic system replacement project has been complete, as well as the parking lot repaving project has been completed. And also IV pump equipment was purchased as well and completed. And in Barrier, really pleased that our fire sprinkler system project completed at a cost of 236,000, and also the boiler replacement project is complete. At Royal Inland, the investments, of course, are Gagliardi Tower project, which was a significant 417 million total investment. Also includes the Patient Care Tower, which you can see in front of you, our phase 2 renovations and ER expansion with equipment, and our ACE project, all in progress. And our phase 2 work is commencing with expected completion in the summer of 2026. The clinical service building project was completed at a total of 67 million. Elevators, various elevators at the site have been replaced over the past 10 years, and most recently 3 have been modernized. And this is really important work. Sometimes, you know, parking elevators seem minor, but they're not when they go down. So really pleased to have that. Our med stations, we've had various med stations. That project is complete, as well with pharmacy renovations. That project is in progress with our expected completion in July of 2022, and that does total 2.8 million. Our CT scanner project is complete, as well as the SPECT CT scanner, and the automated chemistry analyzer system project is still in progress. And our meal delivery system project is also in progress. So overall, I'd like to say thank you. Thank you for inviting me. It's a pleasure to be here and a pleasure to be joining each of you in representing your areas. And I certainly do want to continue to work together so that we can deliver the health services that we need and ensure that they are sustainable and meeting community needs. So thank you. Chair Christian, I'd be happy to open for any questions.
I am sure that there will be questions, but thank you for that comprehensive report. And thank you for that one slide that indicated that the contribution of the Thompson Regional Hospital District over the last 10 years was $218 million. Those dollars came from our constituents, from the taxpayers of this region. And we hear from them regularly about concerns that they have related to healthcare in this region. And they're concerned about their return on investment in terms of their contribution to that. And I'm kind of surprised that when the president was here and speaking with physicians and nurses, that the big thing that came up was access to scrubs, because it doesn't reflect what I have been hearing as a local politician, and I suspect some of my colleagues as well. We're hearing things like issues related to ER delays, issues related to ER closures. We're hearing issues about diversion and bypass from hospitals, both Royal Inland and feeder hospitals. We're hearing about surgical postponement and cancellation. We're hearing about limited access to long-term care and extended stay in acute care. And we're hearing about a lot about nursing shortages in particular. And we're hearing from staff directly about their frustration and their anxiety about being able to practice within their scope of practice, as well as mental health issues. So I'm sure that directors will have some questions to canvass some of those things. And first up, I have Director Rice, Bass, and Quinn. So Director Rice, go ahead.
Thank you, Chair. And thank you, Diane, for your presentation, and congratulations. And I would like to say I really enjoyed our chat at the tour, and what a marvelous facility. I'm hoping it goes ways towards, I think it's a valuable tool in the toolbox. Let's put it that way. Such a great facility on retention and retaining and recruiting and all that kind of good stuff. Going down the road, that being said, from my area, one thing I did run into fairly recently, I've run into a number of things, but I'll try to keep it as brief as I can. But my wife had to get prescription, and they've got a temporary facility at Stein Valley set up, see the doctor. That was a little struggle to see the doctor, got in there. But and this is widespread, once you see the doctor to get your prescription, with no pharmacy, you have to go all the way to Kamloops if you're at Costco. The closest you can't get to Merritt, because Highway is closed. Maybe the Lytton people can get to Lillooet. You could possibly go to Ashcroft. The line now at Ashcroft to get a prescription is approaching an hour if you go there to get one. So there's an overload there. But it not only puts a little bit of an inconvenience when you got a 2-hour drive once you visit the doctor, one way, so it's 4 hours both ways. It also raises the price of the prescription considerably with the gas prices. So there's a cost there involved, and there's an inconvenience for sure involved. I'm the one that had to go to Costco to get that damn prescription after I dropped my wife off to work at the packing house. So I really was up close and personal. This is not good, you know. So I don't know when a pharmacy is going to get there to join the thing, but it's just something I wanted you to be aware of. And as we come up on our first year anniversary of Lytton and not being there, and yesterday was the 7th month anniversary of Highway 8 not being there. And I just got home 2 weeks ago, and I'm one of the first ones home on Highway 8. Mental health continues to be a huge issue in our area, and support for mental health seems to be a very rare commodity in our area. I will say I have got a call from Jeffrey a few times asking how it's going, but you know, I just want you to know that it's a struggle, and it's the first chapter of rebuilding Highway 8, Highway 1, and Lytton. Neither one has really had any rebuilding done at all. So this is a 2-3 year thing. And so it's just a long ways away. We're just on the first chapter. I just want you to be aware of it. And, but anyways, that's sort of all I had. Thank you.
Yeah, thank you for that. I really appreciate it. It's important to understand, even though Interior Health, as you know, we don't own and operate pharmacies, but having those barriers are really important for us to be aware of. At times, we can get innovative and help support some of that development as well. So I appreciate receiving that. Mental health and addictions is top of mind for us all. It did report to me until just recently, our network, of course, the Opioid Crisis, and really pleased to have Dr. Carol Fenton joining us today. And there is, working with Ministry, a robust action plan response. We did move the network to primary care in order to have more concentrated support on that important work. So absolutely, it is affecting many communities. It does weigh heavy on each of us, and we are hearing the need and the need for quick response and action.
Director Bass.
Thank you. I have 3 questions. Thank you for coming today, Diane. This is helpful. The director, Chair Christian, has echoed pretty much every concern I've raised in the last several weeks, but I have 3 specific questions. I'm wondering when the bone density clinic on the North Shore might reopen. I'm wondering how we're going to get the urgent care clinic to actually be responsive to urgent care. And is it true that the Ray Fawcett Breast Clinic only responds to Kamloops residents?
I will have to get back to you about your first and third question around the bone density clinic. I don't have that information, unfortunately, today. As well, I'm not aware that we are only for the breast health clinic focused on Kamloops area specific clients. So I will commit to getting back through Chair Christian those answers. In regards to the urgent primary care center in Kamloops, yes, there is significant work that needs to occur there. And that is why we have now, as of July 4th, Lisa Zeta-Zanata will be assuming the executive director of Kamloops community, with her primary focus being urgent primary care. So we recognize it is not meeting, it's providing a service, but not meeting the need of the community. So that will be focused work.
I'm just wondering if any of the other people who you have on the call might be able to answer the other 2 questions before I put down my hand.
Bone density and Ian, do you have the answers?
No, sorry, I do not.
Okay.
So we'll endeavor to get those answers from Vice President Shendrick and through myself back to the entire board. Next up, I have Director Quinn from Blue River Avola.
Thank you, Chair. Thank you, Diane, for your presentation. I've heard an announcement recently that staff allocations are going to be passed back to the local communities. Is that correct? It seems that they used to be, and then there's this central planning for allocation of staff, and now
our staffing center.
Yes,
that has been more regionalized.
Yes.
It will continue to be regionalized, our staffing, but we are focused on how we can support our site managers and more locally the staff needs. So that decentralization won't occur, but we are looking at opportunities to be able to support the more local needs.
Okay, thank you. And there's no point in asking the other questions. You've already answered them. The other thing too is there's been numerous closures of the Dr. Helmicken emergency room on weekends and the Blue River Clinic, and all due to lack of staffing.
Yes.
Is there a way to address that? Because obviously what you're doing now doesn't seem to be working.
Yes, and certainly sustainability of all of our services is a priority for us all. So recruitment and retention is top of mind, and we are focused on that, and how can we recruit people and retain them within our rural communities. So we are doing our very best. It is a priority to stabilize, and even through our agency nurses to help sustain those services. So our vacancy rates are high as well within rural, and we are looking at how we can together address those issues. So I would say there is a collective opportunity, and our communications department will be really important, because we need to showcase the beauty of these communities and what we have to offer from a health service in order to attract people to the communities. So it is our staffing vacancies, and in some cases also physician that we are really focused on, so that we can reduce, or our goal of course is to have no diversions of any sites.
Thank you.
Thank you. And my next group of directors is Director Brown, Director Roden, and Director Stamer. Director Brown from Merit.
Thank you, Chair Christian. A number of issues, but one of the biggest ones is a community who no longer relies on physicians to help diagnose because of the lack of healthcare over the last little while, and especially with the changes to the physician-patient ratio. Patients are not presenting anymore with one or two symptoms. They're waiting until, as you're well aware, it's not unique to Merit. They're waiting for a number of symptoms, and sometimes presenting a lot later than what they should be presenting in order to heal. We're finding that throughout the community, but we're also finding it with new families. We're looking at trying to gain some economic development in the community. We cannot hire young families because there is very little healthcare in Merit. We do have that beautiful emergency wing, but we don't have visiting specialists. We don't. We could be perhaps accessing our OR for overflow for Royal Inland for some kind of service, but we don't utilize that either. We're not an active hospital anymore, and it's becoming an issue with trying to reinvent ourselves again after the flood. And it's just, we need services, and especially the ability to have visiting specialists. And especially in the wintertime for those elderly seniors that have to come in for dialysis, or 3 and 4 times a week on ugly roads. It's just, if we can do something in terms of visiting specialists and even having a rotation, it would help. I can tell you that I am more than willing to engage with IHA on a regular basis to give you updates on what our city is doing in order to try to modernize and bring staff in. But we need IHA at the table. So, and I'm more than willing to do that. I think it's crucial that you understand where we're headed and what we need in our community. I don't really have a question. It was mainly comments, but I have a health admin background, so I am more than keen on being able to help the process. I'm not there to hinder in any way whatsoever, but I for one would love to have that ongoing continual engagement. Yeah, I think that's probably about it. One of the things I did want to mention was the city of Merritt has lost about 1/3 of their staff, and a lot of them senior managers, and we're trying to bring them in and bring other individuals in, and it's healthcare keeps coming up again and again and again. So it is crucial that we have better access to healthcare. The Florentine has just reduced 32 long-term care beds, as you're well aware. They have just told us yesterday that they are now opening their second bed to community members who want to rent these rooms. So I know that healthcare is a issue for bringing in healthcare staff as well. On a temporary basis, we have the availability of these long-term care rooms. Unfortunately, we've lost 32 long-term care beds, but another issue for another day. But thank you for listening.
Thank you. Certainly, we would welcome the opportunity to meet. So happy to connect with you around who would be best to do that, so we can meet the needs of both sides. So thanks for that invitation. I do recognize the challenges that you've just shared, and I think many communities can probably echo the same. Certainly family practice physicians across the province, which Interior Health doesn't oversee family practice, but they're choosing for various reasons as well to either leave or relocate their practices, which has impacts. And I know that there are discussions that are occurring at a provincial level, both to help support having family practice physicians and specialists and locums, so that we can look at different avenues, whether it's international or from broader within Canada, as well as healthcare professionals as well, so that we can welcome people to the province much easier and sooner, but still meet the quality of education requirements that we do have, our standards. I absolutely can understand your dialysis example. I am an old hemodialysis nurse that had the pleasure, that's where I actually stepped into my leadership roles, because I had the privilege of being a hemodialysis nurse and serving from, it was in Saskatchewan, from Saskatoon and the whole north. So the burden of travel, I completely hear you and understand, and particularly after having a hemodialysis treatment, as well as really supporting people to be independent in their communities through some of our home therapies. So the renal network does report up to me, and I still have a real passion in my heart for that work. Absolutely, and it is challenging. And I also agree with your comment, certainly through the pandemic, and we're hearing it at our through our emergency department physicians and staff. People weren't accessing care, and now they are coming in, and disease burden has increased. So we are seeing that and do recognize that.
Thank you, Director.
Thank you.
Roden from Ashcroft.
Thank you. At the risk of flogging a dead horse, communication. I've been saying this to Interior Health for 3.5 years. There's confusion when we have our planning table meetings. No one is certain what we can or cannot say to our communities. No press releases or press bulletins come out telling us what we can say. When press releases do come out, they are misleading. For example, a recent announcement about a half-day blood clinic in Clinton every week was posited as a gain for the community to cut down on travel for Clinton residents. What it did not mention is it comes at the expense of the clinic in Ashcroft, which is now closed on Wednesdays. So between the two communities, we have gone from having clinics open 7 days a week, 5 days in Ashcroft, 2 in Clinton, to 4.5 days a week. And it's posited as a plus, which it is not. I have been imploring Interior Health imploring them to come to our communities and speak directly to people. And I will give you one example. In Ashcroft, we have seen our formerly full service hospital that had a maternity suite. It had recovery beds. You could perform minor surgeries there. It had a 24/7 emergency service. It is now a 21-bed extended care facility with emergency services that have been chipped away and chipped away and chipped away until in January, we were told we were having a temporary curtailment of hours to deal with COVID staffing issues. 5 months later, those temporary hours look set to become permanent. That is what the community sees and other communities see time and again, it's the death by 1,000 cuts. And every time it happens, Interior Health tells elected officials, this is only temporary. Residents, you don't hear from the residents, we do. And what we hear from them is, here we go again. It's another temporary cut, which is going to become permanent. And eventually they're just going to close down our hospital. So please, could Interior Health send someone to our communities to engage directly with residents and tell them the truth? Whether, are they temporary? If so, when can they expect to not be in place anymore? If they're not temporary, if they're permanent, please level with people, because we are the ones who are taking that day in and day out. And I'd say it's not fair, but I learned in kindergarten that life isn't fair. But please, Interior Health really needs to step up to the plate here and communicate to all the residents of this region, because they are scared, they are stressed, they are confused, and they are leaving our communities because of that.
Thank you. Thanks for that feedback. I do hear you. So we'll take that away. And certainly with now having a communication director focused on this area, we will absolutely strive to improve our communication and welcome an opportunity to come to the community. So I will either speak to Carl Meadows or myself or both, and we would welcome to come to Ashcroft.
Thank you. And I think it's good that the new director is here today to hear those concerns directly from our directors here. Next up, I have Director Stammer from Barrier.
Thank you, Mr. Chair. Thanks very much for taking your time to be with us today. I think the directors already have explained a lot of the situations that we're all facing in our communities. And I got a couple of questions, actually specific questions, but I'm gonna be waiting also for Dr. Fenton when you talk about the primary care for the opioid crisis, because, you know, we're seeing a backlog at Royal Inland Hospital in the emergency room and in the primary care. And with what's happening is the ambulances are being backlogged as well. So now we got people waiting in the parking lots for hours at a time to be admitted into the hospital, and that's causing a backlog back into our communities and for counts as well. And you know, as a personal note, I know of someone who had recently fallen unconscious, had to be driven themselves to Kamloops, and because there was no ambulance service available, and after 5 or 6 hours and finally getting an x-ray with a broken bone in her back, all Royal Inland Hospital could do for her was give her a bag of morphine and send her home. That's a true story. And so I've got a couple of questions. Number one, I'd like to know what's actually happening on a daily basis in the emergency room, like how many patients a day, comparing it to COVID numbers, so that we can actually get a feel on what's really happening. And my second question is, how many empty beds do we have in Royal Inland right now because of lack of staff? I'm hearing patients having to bring their own pillows, a bunch of different things that are going on. So can you tell me how many empty beds we actually have in the hospital that we don't have staff for?
So in regards to the beds, we actually did open additional beds prior to opening the tower in order to accommodate the demand. This morning, our occupancy rate at Royal Inland Hospital we're at 115% occupancy. We have been averaging about 106 occupancy level at Royal Inland because of the focused work that has occurred around what we term access and flow. So access and flow is really important to ensure that we get the each person who are accessing services to the right place at the right time, and ensuring that those that are waiting for community services have that access so that they don't remain in hospitals. So we have those urgent beds available for those who need acute care services. There has been focused work at Royal Inland, and I would share with you that the occupancy rate was significantly higher. So the work has improved in regards to our occupancy rate, and it does ebb and flow each day, depending who is accessing those services. Our staffing levels are what is impacting at Royal Inland, and that's the focus on our recruitment and retention because of our high vacancy rate. We need staff to join and to provide the care. So staff are doing their very best. We've brought in additional people through both our urgent response team and our agency nurses, but also other supports to help support direct nursing so they can be focused on the direct nursing care that is needed. This morning in critical care, of our 17 beds, we had one open bed in critical care, and that's what we look to achieve because we need to be able to respond to anyone who needs that level of care. And we work as a system within Interior Health to ensure every person who needs a critical care bed has that access, and even broader provincially. I'm not sure if I've answered your direct question, so I'll just pause.
I think there was another question in there about the offloading of ambulances and the subsequent delay of the ambulance system into the region. Yes, ambulance must be able to offload to the emergency department in order to return back to their community. And based on that flow through the hospital, yes, there have been offload delays, but it is also coupled with our ambulance service is also struggling with high vacancy rates. And so I wish there was one single clear answer I could give you, but the combination absolutely does have impact. We are looking at an opportunity because we're hearing from our paramedics in our rural communities who are in the community on call. They're looking for some opportunities and saying, how can we help? So we've begun those discussions to how can we better utilize and support our paramedics in the local community. And that's through what I call community paramedic programs, where I've had some great experience to help support. So we're also exploring those avenues as well. Can someone get Vice President Chendrick a glass of water? Because we're going to be here for a bit. And I have on my list Director Smith, Elliott, Watson, Polderman, Rain, Rothenberger, Duty, and Walsh. Then we're going to. I might take your whole meeting today. And Schaefer, welcome. And then we're going to move on to Dr. Fenton. Please bear with me. We've waited a long time to hear from Vice President Chendrick, and I think the issues that are being canvassed are quite reflective of all of our communities. So, but I'd ask directors to be fairly succinct with their questions and be conscious of the time. Director Smith from Logan Lake.
Thank you, Mr. Chair. And as you can tell by the interest in the board, it's a big deal for all of us. I kind of echo the words from Ashcroft. We've been in much the same boat. Many years ago, we had a full operating, emergency room and all of these other things that we don't have today. And as I'm sure as Ian Nelson knows, we, as late as even this week and last week, I've been concerned that we may be getting that phone call that our health center is also closed due to staffing issues. But the challenge is that these issues have been there for 3 years. The people in the positions that are there are getting burnt out. They're not getting compensated probably to the levels that they should be to make that actually worthwhile to them. And to be quite honest, my sister's an MOA. I tried to recruit her back and she said, there's no way in heck I would go back to what I was doing when people would come and yell at me after I haven't answered the phone for hours. And I could tell them I haven't been to the bathroom since 6 a.m. and I haven't stopped running. And she's an MOA, answering telephones and doing all of these other things that they shouldn't even be really doing, but they have to do. So it is a challenge. And I don't think that it's an easy answer, no question. It's tough. I do think that wage structure needs to be looked at for some of those support positions. When you're looking at minimum wage being almost $16 an hour, and then you're looking at a MOA that's maybe making 21, it's not that attractive. So I do think that's an issue. Good to see Michaela. I haven't seen her for a long time, but I remember her in many past positions, so it's nice to see. And I also want to just mention, I don't know if there's an opportunity to look at recruiting back some of your retirees that have retired, because I see the RCMP is doing that because they too are in a crisis, and recruiting back through their I think they call it the reservist program. So I just want to throw that out as maybe an opportunity that might be out there for people that aren't quite as tired, that have maybe had a bit of a break. And the other thing I just want to end off on a really good note is that our Dr. Mo actually was awesome during our fires. She managed to get herself set up in a hotel room in Merritt and had support from Interior Health and the divisions of family practice, who are definitely your friend, by the way, and was able to actually continue to see about 75% of her appointments that she had previously made, and reached out to let us know, just to put it out there, that they were not going to be canceling and they were going to be accommodating those appointments during that period. So I thought I would at least just give you one little tidbit of good, because it has been tough on all of us. So thank you, and nice to meet you.
Yeah, I acknowledge it's very difficult, and very difficult for communities and community members. We work within our collective bargaining agreements. So certainly we can't work with outside, but I can assure you that their Interior Health has members on those provincial committees. So certainly our voice is there as well. People are stretched, absolutely, and doing roles that exceed what their normal work duties would be because of our vacancy rates. So I do want to acknowledge that. We are looking at how can we bring back people who have chosen to leave, whether it is retirement or for other reasons. I've invited people to meet with myself directly. Human Resources also actively looking, and they will be rolling out a strategy to call people actually in person as well. And it's my hope next week that we'll have something to announce that will entice and hopefully welcome people back warmly to the needed positions. And on a personal note, Logan Lake is dear to my heart. I have an over 95-year-old great uncle and aunt that live in the community, and having moved here has brought me closer to them, and certainly have heard from them as well. And they love the community. Have been there a number of years. I'm sure you know them, but yeah, yes. So absolutely, these are important communities, and access is important, and it's important to us.
Director Elliott from Savanaw.
Thank you, Mr. Chairman. Yeah, one of the things that was on your slide that you gave us was a 1.8 million for upgrades, I gathered, to the meal system.
Sorry, I'm not quite hearing to the which?
Oh, the meal
system. Yeah, the meal delivery at Royal Inland. Yes.
Yes, I wonder if you could tell me about that, because I am going to tell you, as a patient of Royal Inland Hospital, your meals are deplorable. There is no way that you can continue to get better at Royal Inland with the kind of nutrition that you get. We all know that nutrition is the thing that helps you get better. And I spent 8 days in that hospital, never once had a meal that worked with my diabetes, and I lost 12 pounds. So I hope that that 1.8 million has done something to provide meals to patients who are in need of good nutrition. Could you tell me what that 1.8 is?
I'm going to look to finance. It was for the meal delivery system, not around the food. Corey? Thank you.
So I can speak to that. Kamloops, we're actually just starting the project right now, but Penticton was actually our initial site, and it just started up in the last 6 months. And there's kind of two pieces to it. One is around how the food's actually delivered. So we've got old antiquated food delivery, and this is now moving to a whole new system where food's delivered or prepared and delivered hot. So that's going to improve the quality. The secondary phase of the project is actually a menu planning piece as well. So moving towards standardized menu planning across the health authority, and then also giving patients the choice to choose what food they get. So that piece is coming. Like I said, Penticton is just rolling out now. Kelowna and Vernon are next up, and Kamloops, we just got approved for the funding last year. So that will be coming to Kamloops as well.
And are the meals still being prepared in Vernon?
I can't speak to Kamloops specifically. I believe in Kamloops they're prepared in Kamloops, but I don't know.
No.
Yeah.
They are now being prepared in Kamloops?
Yes.
Okay.
Very good. We're going to move along to Director Watson from Green Lake 70 Mile.
Yes, I had a good news story, and I thank you for Interior Health, but I realized it was in a different hospital district. It was 100 Mile Hospital, and their good service and their good meals. Sorry.
I believe Vice President Shenrick looks after that hospital as well. Director Polderman from Lytton.
Hello, thank you very much for your presentation. You know, I understand that IHA was the employer of choice when it came to recruiting and retraining employees. And, you know, we seem to be in the same situation now as we were then. And so I'm sort of wondering if IHA has looked at why that program was unsuccessful and what they have done to fix those problems so that the retainment of your employees is a little longer than what it was in the past. Thank you.
Certainly, human resource doesn't roll up through myself, but what I can share is the Vice President of Human Resource, Karen Blooming, who actually had clinical operations here in the North portfolio a number of years ago. I can't recall exactly how long, and as a clinical background is the Vice President leading human resources, so actively supporting that team. I think that there are a number of drivers, and I can only speak from who I have heard from. I think that our vacancy challenges, in all transparency, began before the pandemic somewhat, particularly to rural. When I joined Interior Health from Saskatchewan after almost 28 years in Saskatchewan Health, and was looking for another opportunity to work for another health organization. And I was a registered nurse, as I had mentioned earlier, and then moved through administration and had the privilege through that organization to both have our acute tertiary within Saskatoon, rural, urban, long-term care. I had experience broadly. So when I was welcome to Interior Health to the Kootenay boundary, I'll be honest, when I joined, I knew the rural and remoteness, but until I actually got there and understood what that meant, being so down south, I truly didn't. So one is recruiting people to our communities and welcoming them. It is really hard when our public messaging, and this is where I think collectively we can do something together to showcase the communities and what they have to offer and what Interior Health has to offer for employment. And because right now, of course, it doesn't take much of a search to see the negative. And I think it's important to be transparent, but I also want to balance that with what we do have to offer and what is attractive to coming here, because there's a lot. Going back, and it's not about Kootenay Boundary, but Grand Forks, we did through communications a video that showcased the community, and it actually had the highest number of viewings, if you will, I understand, of all. So those types, and together, what we can do together, and to address what maybe the challenges are. I hear housing access in Kamloops and broader is an issue. So people, we've had a couple of applicants and then they're not able to find housing or a place to live. So with the vacancy in healthcare across the province and across Canada, people can go anywhere. So I think that's where together, what is the uniqueness? What can we bring forward to say, it is great. And I am happy to be a spokesman to that. I am fully committed to this area. It's a beautiful area, to the health services we have. And I think we just need to showcase that and support people to come and live in our communities and work in our communities.
Speaking of beautiful areas, next is the Director Rain from Sun Peaks.
Thank you. I actually probably have a good story because we don't have services for my but we are a little invisible on your plan, I see, but the community has built its own health services and municipalities backstopping it financially, which I will say we're very pleased. We did get some financial support from the province on that, and we're thankful for that, because normally we're not in the healthcare business. But I just wanted to reflect. I had a resident tell me that she was scheduled for surgery, went to the hospital for the surgery, spent 5 hours in the hospital ready for surgery, and then was told it's canceled, come back in August. I mean, I was kind of shaking my head. I mean, I can understand maybe some other critical surgery was bumped her and things just were, people weren't available. She didn't get an explanation. She couldn't understand why, but I mean, if there's recruitment issues, I'd say, well, we should have known at least the night before that we're not going to do this, and at least you get a call. You don't go to the hospital and wait for 4 or 5 hours all ready for your surgery and then get told it's not happening. But I'm happy offline I can give you a name, and I mean, people lose confidence in the system when that kind of news spreads like wildfire around the community. Oh, so and so was down there 4.5, 5 hours waiting, and so go home, come back in August. Sorry.
Yeah, no, absolutely. That does occur. It occurs for multiple reasons. Part is we have to ensure we can provide the surgery, and sometimes there are urgent and emergent cases, but that's not, I'll be transparent to say that's not all the time. Also some of our staffing, and can we provide the level of care post-surgery, because it's a continuum to make sure that that bed is available with the right care providers as well. And at times there are some site things that occur that are unexpected as well that can postpone. But we need to do better in that area. Surgery is, as in my presentation, part of my portfolio for across all of interior health. And it is top of mind. And we do have our wait times that we're focused on in order to improve that access. And we did postpone surgeries, as the communities know, as our staff were getting sick with COVID. But we've actually, I believe it's 95 or 98%, those surgeries have been completed where we postponed. But also our wait lists have gone up as people are accessing care again and receiving diagnosis. So it is a priority for us, absolutely. And we do not want to postpone surgeries for those that are already absolutely on site. So I can appreciate that and prep. And I just visited Sun Peaks on the weekend. Lovely area. I hadn't been up there before, so look forward to seeing your community more.
And our last
let me just do a quick
supplemental.
the issue really is more around, your surgery is postponed. Yeah, I can understand it. You know, next week we're postponing your surgery, but to be there for 4 or 5 hours, ready for the surgery, and then told you're come back in August with no real explanation of what happened. I mean, I think people would even be happy with the explanation to say the surgeon died or whatever, something happened, but we can't do it, you know.
Appreciate that. Thank you.
So you'd be delighted to know you're on your last group of 3 directors. So I have Director Rothenberger, Duty, and Walsh, and then we're going to go to Dr. Fenton. Director Rothenberger.
Thanks, Chair. I will pass and yield my time to Directors Duty and Walsh.
Director Duty.
Thank you, Chair. Thank you, Vice President Schendrick, for putting yourself on the firing line. Not an enviable thing to have to do. Recent discussion has taken place with regard to the crisis of doctor shortages, particularly general practitioners. And out of that has come this confusion as to who's responsible for that recruitment. We have heard some say that it's the municipality itself, and some say that it's Interior Health, et cetera. So I guess my question to you is that what is the role of local government, both municipal or regional, with regard to attracting GPs to their particular areas? And what position does Interior Health have with regard to that? And what are they prepared to do to move things along?
I'll begin to answer, and actually because Michaela just is from Medical Affairs, she might be able to enhance what I'll share. So Interior Health, we don't actually hire and recruit family practice physicians to the community. They are independent businesses, if you will. That said, we do employ family practice physicians, and they also do work within our healthcare facilities. So it is quite a complex model. Certainly there are innovations happening across different provinces and within BC to help recruit family practice physicians to their individual communities. And again, there are, I would say, a shift in how people want to work. So to be the general family practice physician for a community that's on call 24/7, 365, people, that work life has changed through the generations. So I know that there are ongoing conversations through DOXA BC with how to address the issue. I'm not involved in those conversations, but I know that also there's innovation occurring within local communities. Michaela, did I capture? Do you have anything to add?
I thought you did well. So hello, everyone. It's Michaela Swan. So nice to be here. Transitioning today into the new role. My previous role, the last 6 years, has been doing strategic initiatives in the medicine and quality portfolio. So physician recruitment has been a part of that. And you're right, typically, especially in our larger centers, Interior Health has focused on the specialist recruitments and any medical staff recruitment to support our services, which typically has not been family practice. Historically, that's been private business owners in terms of coming into the community and setting up. But over the last, Robin, I think of when you and I worked together, 2013, it's the team that truly brings physicians and retains physicians in the community. So that's the divisions, that's Interior Health at the table, and that is the local government in terms of support and being creative. There's lots of places around the province that are offering different incentives, but that can be a slippery slope too, because then is it just money to solve the problem? But I think we should connect, and I believe the Thompson division as well as STEPS just met with local city council, and I do think we need to take that away and be involved at the table for those conversations here locally and continue them where we already have them established in at the greater TNRD.
Okay, so supplemental.
Supplemental.
And I appreciate the fact that you're willing to go down that road with us, but I think that what needs to be recognized is that we're municipal government. We deal with sewers and dog licenses and things like that. We're not equipped to deal with recruitment for physicians, et cetera. So I guess what we need to establish is what our defined role is with regard to this, and who's going to be willing to partner with us, whether it's Interior Health or any other agency, in making certain that the people of the region and the city receive the type of healthcare they need.
Sounds like a good agenda item for that meeting.
Okay.
Thank you for that answer, Michaela. We're going to go to Director Walsh, but then I've added Director Schaefer because she took a very circuitous route to get here. So I think she deserves the last word. Director Walsh.
Okay, yeah, thank you for coming today. It's been great to have the opportunity. So I'm just looking for some clarification on staff shortages and basically how that relates to the COVID mandates that were instituted back at the end of last year. I'm curious how many, the number of, given now that we know it's very clear, obvious that vaccines do not prevent acquisition and vaccines do not prevent transmission. And not everybody is fully vaccinated at AK, fourth booster or whatever current. So I just wondered the number of healthcare workers, and I've been told it's something like 800 in inland or interior health, but how many specifically at a Royal Inland we lost that were either suspended or terminated, that were suspended without pay, and how many we brought back into the fold now that we know where the risks really are. At the point back then, the risks were more unknown, but now with the Omicron variant, it's pretty clear what's going on. So have we brought any back into the fold? And then, are there these mandates still in place, especially for new hires?
Yes, to work in health authorities, you must be fully vaccinated, and we do require proof of vaccine. So we haven't, that is a provincial order from Dr. Bonnie Henry, and that hasn't been revised. So we work with underneath that provincial health order. So at this time, anyone new or returning must be vaccinated. I don't have the Royal Inland breakdown top of mind right now, but I can share with you within Interior Health, I believe that the number of unvaccinated employees that that left because they were not vaccinated was just over 950 employees. So it did have a significant impact to our human resources.
Okay, just a supplemental, is anybody lobbying to change that? Given what we know now, that that there isn't a risk of an unvaccinated person any more than a vaccinated person. Maybe there's a self-protection for the person, but not for, whether it's acquisition or transmission. Why would we shoot ourselves in the foot and not either get rid of those rules that don't really have any scientific basis anymore?
Well, I think we're going to maybe save that for Dr. Fenton.
I would just say we wouldn't lobby with our provincial medical health orders at all. We work within them, and what is directed by, I would say, evidence of best practice, but we could disagree on that as well. Yes.
And we're going to move to Director Schaefer from Vavenby. And Director Schaefer, I'm glad you're here because the highway is now once again closed with another bad accident at Vinsula. So.
Well, I came down Lake Road and it's quite a road. Sorry I'm late, but I don't know if this question is asked, but in March, I asked about centralizing staff. The staffing was centralized into Kamloops. And at that time, Ian said they were looking into getting back the staffing person back into rural areas. It was taken out of the rural areas. And it caused a lot of problems because staffing just sends it out on your telephone and to see if you can come. And then an hour before they're supposed to come, they put it back to the rural hospital, which isn't enough time to get people. So really they need to, at that time I said, I would like to, my thoughts were that the staffing should go back to the rural areas. I'd like to know if that's being done and if it's going to stay, or are they going to decentralize? Are they going to centralize staffing again?
It hasn't been done. We still have centralized staffing in place. We are absolutely looking at, and in some cases have put positions in place to help support the staffing. Our staffing services, so I would say, yes, there's some efficiencies and effectiveness that staffing is working through, but they too have a high significant vacancy rate that they're managing. It's not just direct patient care that's had some impact. So to my knowledge, at this time, we are not looking at decentralizing staffing services. But again, it's not my area, but to my knowledge, not.
Thank you very much, Vice President Shendrick. We appreciate your candor and your availability. And do you have a supplemental, Director Schaefer? Okay.
I would like to know what we have to do then to get it staffing back to the rural areas, because it's very important that it's there, because at least they know their staff and they can get them in, and it'll cause a lot less closures than we're having. And right now, Dr. Hemilton is closing pretty well every week.
Which, yes, I'm very aware. So the managers are also taking that role and are contacting, I know Heidi is working very hard and contacting staff directly for Clearwater, just to support that work. So we're looking at how to continue to support more locally.
Again, thank you for your time, an hour and a half on the hot seat, but it's because we're passionate about this. It's because the constituents that feed to us are compassionate about this. And it's so important to our communities. And, you know, I think you maybe had a bit of a taste of that today. You have a lot of things to take back. We would like to extend the opportunity to have an ongoing dialogue, not only here, but also in our communities and with our constituents. So thank you very much.
It was my pleasure, and thank you. And I just will close by saying I am equally as passionate, and I am committed and dedicated to the sustainability of our services, as I know each of you are. So thank you.
At item 4.2, it's my pleasure to welcome Dr. Carol Fenton, the Medical Health Officer for the Thompson Caribou Shoe Swap, to provide an update on the COVID-19 pandemic.
Good morning. Thank you for having me. It's nice to see you all again. It's nice to be in this room with you all. It's my first time to this particular part of this building. It's very nice. I believe the last time I saw you all was about a year ago. So I'm glad to be back. And I haven't given a COVID-19 update in a little while. I have transitioned from the immunization portfolio to the mental health and substance use portfolio, in addition to all of my geographic work here in IH West. So it was good to revisit, and I hope I can answer all of your questions. I believe I drive with this thing. There we go. Okay, so I'm going to start with saying I'm focusing on hospitalization and death data to give us an idea of what's happening with COVID-19 in the region, just because our public health testing system is now focused on identifying cases and providing treatment for those who are eligible. So we're focusing the PCR testing. Okay, can you hear me now? We are focusing our public laboratory PCR testing on those who are eligible for treatment, and we are recommending everyone else to use the at-home rapid tests and self-isolating from there. So we have a transition in terms of the data that we are using to inform us what's happening with COVID-19 in the community. And so looking at hospitalization and death data, this is from the BC CDC, so it is provincial. But you can see it's hospitalization and deaths by age group that are the separate colors. I hope you can see those colors. Chair Christian, I, again, did not make the graph. But what you can see here is that we're still seeing fairly high levels of hospitalizations, down from the peak that we saw earlier this year. You can see it's by epidemia or by week of the year. So those weeks 1 through 7, the first 7 weeks of the year, we saw a really high surge. That was our initial Omicron surge. And then we had a decrease of hospitalizations, and then we had a little peak. You can see there's a dotted line. There was a change in how the data was being collected. So some of those rates may be attributed to that change. But, you know, we're in general still seeing fairly high levels of hospitalizations compared to what we've seen previously in the pandemic. Looking at the deaths, we did see a little increase in recent weeks, but we are still seeing low levels comparable to what we've seen elsewhere in the pandemic, which is really interesting when you reflect back on looking at, you know, those initial early weeks where we did not have access to vaccine and we were controlling the virus solely through public health measures. And then we've achieved a transition point where we can rely now on the vaccine to achieve, you know, comparable protection levels. And so that's sort of the theme, the key message that I'm speaking about today. Okay, pushing the button. There we go. Okay. So the previous one was by age group. This one is by health authority. The top squiggly line in gray is BC overall as a province, so it's higher because you're adding them all up. IHA, which is where we are, is the I don't know if it's a dark yellow or a light orange line, but it's very hard to see because it's right in the middle of the pack, which is reassuring and consistent with what we have seen throughout the pandemic, where we generally see more activity in Fraser Health, for example, and we've done really well comparatively, which has been a relief for myself in my position. And you know, you can see that same pattern that we saw across all of the health authorities that we saw in the previous graph. So, you know, big surge, January, February this year, we had it come down sort of April or so, and then we're seeing a little bit of a bump again. So specifically looking at hospitalizations within IH, this graph is from an internal IH dashboard. What we are seeing is, you know, that pattern we saw of hospitalizations that matches what the provincial numbers were showing in all admissions, but you can see that our critical care numbers have steadily and gradually continued to go down. So that's very reassuring, and I like to see that. Oops. Okay. This is another indicator of what COVID is doing in our communities, just the number of outbreaks that we are seeing. So the top one is all outbreaks, both long-term care and acute care, separated by color in all health authorities. You can see it follows a similar pattern to the hospitalizations. And so, you know, reinforcing that the trends that we saw there are matching the number of outbreaks, so really reflective of the activity that we were seeing. So we saw a big surge in the number of outbreaks in both long-term care and acute care earlier, sort of January to end of February this year. It came down, and then we're seeing another bit of a bump right now. The bottom graph is the same thing, but instead of differentiating long-term care and acute care, we're broken up by health authority. And again, we are that sort of light orange color, which shows us, you know, not to be the most affected in the province. And so, you know, I'd like to see those numbers be lower, but it's reassuring that we are not the most affected and that we are seeing similar trends and patterns. Oh no, my bicycle's in the rain. Sorry. So another way that we can monitor how much COVID activity that we have in the community is through wastewater testing. I have been requesting wastewater testing since end of last year, and I'm told by BCCDC that it's coming. I know that we have state-of-the-art wastewater facilities in Kamloops, and we are one of the candidates in the interior to get that surveillance system. I just haven't heard from BCCDC what the timeline is on that. I'm hoping it will be soon. I was told this week that there was going to be an announcement, so I'm definitely staying tuned for that. For now, we rely on our closest neighbor that has this surveillance system, which is Fraser Health. And what you can compare here is the sort of black and white dots are the wastewater surveillance data. And then the continuous blue line are what the public laboratory testing shows us. And so you can see up until, December of last year, they were fairly close to each other. And we saw the surge and the peak in both of those early this year. And then we've seen a bit of a decoupling. And that is again explained by the fact that we are not broadly testing the population, but it is reassuring that we are still seeing a lower trend, at least compared to what we saw earlier this year in the general wastewater, which gives us an idea again of whole of community COVID activity. So hopefully we will get that for our own community soon, and we will stay tuned for that. So switching gears a little bit and talking about our public health control measures. This is where we are at in terms of the interior health population's current stage in vaccination. Along the x-axis, we have age group. Along the y-axis, we have the percentage who are vaccinated. And then the colors we have here are dose 1, dose 2, and dose 3. And then the gray folk are those that have no doses. What is a delight for me to see is that over the age of 74, we have nearly 100% coverage, at least to dose 1. And I believe we're well over 85% to dose 3. So that's the booster. And so as you probably already know, that the most important risk factor for hospitalization and death against COVID is age. And so it's really heartening for me to see that those folks are protected with that vaccine. And that is again reflected in those steady decline of numbers that we see in critical care. And so those are all numbers that I find very reassuring. What's not reassuring is what I call the upside down triangle of danger, where we see a steady decline of that vaccination coverage as we go down the age groups. And so obviously the age 6 months to 5 years don't even have a vaccine yet, so they're not even on the graph. But what you can see on the far right-hand side of the graph is that our vaccine coverage for that youngest age group that is eligible, the 5 years to 11 years, we're seeing really low vaccination uptake and coverage. And so that is really concerning because, COVID-19 is very much still circulating. It is lower than it was earlier this year, but it's definitely still in the community. And so we are seeing differences in coverage throughout our region as well. So there are differences geographically. I'm happy to say my own little geography of Kamloops South is one of the highest, which I love to see. But what I don't love to see is that we are seeing differences across the region, and especially our neighbors further west tend to have lower vaccination rates. And so especially coupled with, perhaps access to services in those areas and other health issues, that's really concerning that there are more people in those areas that don't have this protection. And so this is a graph showing second dose coverage. So this is just the primary series, not even talking about the booster, ages 12 and over. So we're not even talking about those lower age groups where we're seeing lower uptake. And this is as of this week. So it is current data. And then similarly for the first booster dose, we have lower uptake. I did put the exact numbers in the notes, but I don't have them memorized off the top of my head. But we are geographically, we're seeing a difference in uptake. So in our urban area of Kamloops, fairly good uptake, but the geographies surrounding that, there is less coverage. And so we're losing that protection against hospitalization. And then just talking about the effectiveness of the vaccine. This is an older graph, but it still holds. What we see, where's my, oh, it's on the right there. So for the colors, we have the new daily cases is in green, the blue is hospitalizations, and red is critical care. So you can see as there is a dramatic difference between the unvaccinated and the vaccinated population. What we are seeing here is the green line is cases. We lose that protection against entire prevention of infection against the Omicron. Everyone can relate to this. So we're seeing more infections in their vaccinated friends and family than ever before. But that protection against hospitalization and critical care was really important. And you can see it was almost half the rate. Whoops. And so this is a study that was done out of BC CDC, and it really explains that pattern that we were seeing. So this is 2-dose vaccine effectiveness as a percentage compared to adding that booster dose, that third dose. And so on the left-hand side, you can see, and along the x-axis, we have a number of weeks. So the first dot is September to October of 2021. The next one is October to November. The third one is November to mid-December. And then the fourth one is mid-December to early January. So it's just a snapshot. But what we saw was with the blue dots, or the lower set of dots on the left-hand side, we went from 89% protection from any infection entirely down to 6% effectiveness with 2 doses against any infection entirely, which was really sad to see. But what we can see there is when you add that booster dose, you go from 6% prevention of infections to 60% prevention of infection. So that is a dramatic increase in protection, and that's protection from any infection at all. And so that's really important. The reassuring thing for me is that we didn't see that dramatic loss of protection against hospitalization. So you can see it dropped down to about 87, and then that booster bumped you back up to 92%. That's 92% prevention of infection compared to someone who is not vaccinated. So again, vaccines are really, really important. They are the reason that we don't have to rely entirely on those social distancing, masking, non-medical infection prevention measures. And it is the picture that we are at today, but COVID is still very much in our community, and we desperately need to prevent as many hospitalizations and critical care admissions as we can, so that we can support our health system to get where we need it to be. And so that's what I brought for you today, and I'm ready for your question.
Thank you very much, Dr. Fenton. I know many of us have had the opportunity recently to get back into the public and speaking. And one of the things I mentioned some months ago when I was speaking to the Chamber of Commerce was that we're all done with COVID, but I don't think COVID is done with us. And I think the data that you've provided today shows that COVID is still prevalent within the communities we represent, and that vaccination is an effective way of preventing both the incidence and the seriousness of illness. Director Quinn from Blue River.
Thank you, Mr. Chair. Thank you for your presentation, Dr. Fenton. I want to change the subject, if I may. The last time we met, I asked you a question about the second health emergency, that the opioid crisis. Has that since that time improved, stayed steady, or deteriorated? It's a simple question.
So looking at the statistics that we have for this year compared to next year, we are seeing an improvement. Even better than that, my colleague MHO Dr. Karen Goodison wrote the MHO report this year, going in depth to some of these issues. And the statistics showed that more than 2/3 of deaths were prevented from the toxic drug supply. So the interventions that we have in place are working. We still have a lot of work to do to expand them and make them accessible to everyone that needs them, in addition to all the work that needs to be done to improve the safety of the toxic drug supply. But I'm glad to say that the work that we are doing is working.
Thank you.
Director Stamer from Barrie.
Thank you, Mr. Chair. Thanks very much for your presentation. I can speak for firsthand that yes, COVID's still around from last week. My question is similar to Director Quinn, in as much as that, can you elaborate a little bit more on what this opioid crisis is doing? I asked a question previously about our ER and some of the issues that we're having, and it's affecting not only the people that are having those issues with them from the opioid crisis, but also the downtown trickle-down effect. Like I mentioned, we're having backlogs in ambulance services. We're having issues where people aren't getting the care that they timely care that they probably should be because of what's actually occurring. Can you elaborate on exactly what's going on and what we're trying to do to improve what's happening at that primary care, critical care situation in Kamloops?
So I will limit my response and say I have an entire presentation on this that I would love to come and give if you want to invite me back. But there are a broad spectrum of services that are really important to prevent, protect, and reverse the effects of the toxic drug crisis. And many of these can occur in community that reduce the burden on the health system. And many of these can also happen in the health system and need to happen in the health system so that everyone can get care. And so it is work that is occurring across the spectrum, and there's a lot going on.
Final word.
Hey, Mr. Chair. When are we gonna get the information on what's actually going on, and not just a 30, 60, 90 day a plan that we don't really get the specifics on?
Right. So if you want to connect with me offline and let me know what community you're from, and I can look into what exactly is happening in your community as well as what's in motion. Because every community is different, every community's needs are different, and what is appropriate for every community is different. And so there isn't a broad IH-wide, we are doing XYZ plan. That's why I can't speak specifically to it. But we're specific in terms of the specific interventions that I think are really important to our overdose prevention services. These can be specific locations, or they can be episodic within the health system. They can be with an outreach nurse that goes around. Access to treatment. There's a new virtual opioid and a general addiction service that's going to be available, that people can actually start their treatment in home, accessing that service virtually. So that should increase access across the board in many of our jurisdictions, as well as many other things. And one of the things that I am trying to do now that we have more flexibility and less restrictions is actually travel to communities and speak to different groups, including city councils, around what is needed on the health system side, and then what is also needed in community to address this issue. So I would love to speak more about it.
Thank you. And final question goes to Director O'Reilly from Kamloops, and then we're going to move along.
Thank you, Mr. Chair. Thank you so much for your time, Dr. Fenton. Obviously, you've had a busy year, and for your note for riding your bike, we are constructing a protected bike lane that's going to run from 6th Avenue down Lansdowne Village up to Sally and the government precinct. So you'll have a safer ride by the end of summer. But I just want to touch on the graphs that you had and the way that they were overlaid, specifically as it related to the health authorities, that was on there for hospitalizations. But then when we flipped and went into vaccines and the rates of vaccines, it was broken down to a much smaller area, which is fantastic. I'm wondering, obviously you can't do it today, but the next time you come back, I think this board would be very interested in seeing the overlay of our specific region versus, the Okanagan or the rest of the province, rather than being lumped in as IHA, because we are a different area, and right. this room of directors represent our area, and so that's really, I think, would be a big interest for us, or even have just this area overlaid IHA and then the rest of the province, just to help break it down so we can understand what's happening in our specific region. But other than that, that's my really only comment. But thank you again for your time.
Okay, thank you.
Thank you, Dr. Fenton. Always a pleasure and good to see you in person.
Thank you.
We will invite you back. Next up at item 5.1, we have the Thompson Regional Hospital District Remuneration Bylaw number 154/2022. Chief Financial Officer Ray.
Thank you, Chair. So the timing is a little bit strange because the TNRD remuneration bylaw and expense policies coming to the board meeting this afternoon for consideration. But for the hospital district remuneration, for some of the directors in the hospital board who might not have already been part of the discussion with the TNRD prior to this, what we're doing with the TNRD remuneration bylaw is separating the expense piece. The expenses will be in a policy and the remuneration bylaw will deal strictly with remuneration. We're doing the same thing with the hospital district bylaw. So this update really just takes the expenses out of what was in the previous bylaw, and it's going to refer directors to the same policy that directs the TNRD board expenses so that there's parity in terms of the rates. And otherwise, what's left in here dealing with the indemnities and compensation, the main changes would be the per meeting rate. We're proposing to increase it from $160 to $170, which again would maintain parity with what's proposed in the TNRD remuneration bylaw. And that's really, it hasn't been updated a number of years. And the intent long-term is to allow for a cost of living increase reflected largely against CPI in the province. And so looking back from 2019 until now, and actually skipping 2020, that's where that $10 increase, we're just doing it in larger chunks rather than just a few dollars each year. Typically, section 2 in the bylaw shows the annual indemnity paid to the chair, and that would typically also have a CPI increase, but Chair Christian has respectfully asked that it remain the same this year. But section 19 of the bylaw deals with indexing, and it basically just says in there that going forward, the CPI increase that would be applied to the annual remuneration in the TNRD bylaw would be mirrored here. So that again, just whatever rate that is, meant to be the annual CPI for the previous year in the province. But if for some reason the board were to opt for some different change, it would be mirrored here in terms of what the chair here gets. That's primarily the changes to the remuneration bylaw.
Thank you, Chief Financial Officer Ray. Questions of Chief Financial Officer Director Rothenberg?
Just a procedural question. Could you refresh me, Mr. Chair, on when amendments may be proposed? Do they have to be done before consideration of first and second reading, after second reading, or at what point?
I will defer to the acting corporate officer.
After the second reading, please.
Thank you. Director Walsh.
Yeah, I mean, I have a real problem with this indexing to the CPI like a COLA clause, because if you recall back in the 80s and that, the COLA clauses, basically they contributed to even a worse inflation in the 80s there when we had the up to 21% interest rates and et cetera, right? And the current index in the US is somewhere disputed between 6 and 8% inflation. Like we're running on almost a hyperinflation right now. And to me, that's the wrong time to institute, you know, measuring yourself to the CPI, you know, the Consumer Price Index, because it doesn't look like, unless they raise the interest rates astronomically, that we're in an inflation, hyperinflation. So I don't think the taxpayers would appreciate us being kind of tied to that. To me, I think we should be looking at comparable regions, or you know, to see how we compare to regions in BC all in, rather than this strange measurement that we know when it's okay in a normal time of economic times, but right now we know where we are, and we know, and it doesn't look like it's going to get any better. You know, obviously with commodity prices and war and et cetera, right? So I just think the timing is bad, and we're just going to compound the problem by, if we have to, you know, look at the CPI and we're giving ourselves 4 or 6% raise while other people are having trouble putting food on their table, it's just not going to, the optics are going to be terrible, right? So I'm just saying, I know this is coming to the meeting this afternoon too, but I think we should look at comparing, like, let's say City Council as an example of Kamloops. We have a comparative of 13 communities that are somewhat comparative, right? And so we don't get involved with the CPI or any other measurement device other than our colleagues, right? So I think that's a safer way to go than it is, especially with what we see in front of us right now. And I don't see any correction right now that isn't going to be upsetting to most people, right? So, but maybe you have a different viewpoint of what's going on, but I think as of today, we can see where inflation is.
CFO Ray?
Yeah, through the chair. Yeah, it's really a kind of a chicken and egg question, isn't it? Which is driving inflation. I think, you know, it's clear that we are in an inflationary environment right now. You know, we've had concerns raised about the cost of gasoline and things of that nature, that directors incur those costs in performing their elected duties. Regarding your comment about a broader comparison, we do that here as well. We do usually once every 4 or 5 years a comparison. We're set to do it in the coming year again. We do a comparison against basically the surrounding regional districts, with the long-term strategy that we've held for quite some time is to be at that market average, not leading, not lagging, but sort of strike an average. I do know that most of the other regional districts and likewise hospital districts, from talking to the peers who work there, they apply a CPI average. So where we do get to that point of doing, not annually, but every 4 years or so, a comparison. If they're applying a CPI average and we're not going to be at that average, we're going to find ourselves lagging. That's completely up to the board where they want to be.
Thank you. I have Director Brown, then Director Elliott, and then I think I'll test the will of the board on the recommendation. Director Brown.
Thank you, Chair Christian. I just had I think a couple of comments, and I just trying to compare what we're doing here with what we're doing at the TNRD level. And at the TNRD level, the annual indemnity for chairing a meeting is included as part of the full annual indemnity. Either or, whether we go one way or the other doesn't really matter to me, but in my mind, they should be consistent. This is a creation of TNRD, so it's probably should be some similarity there. What we're looking at the Thompson Regional Hospital District, excuse me, is $200 for chairing a meeting. There's nothing in the TNRD, and I know nothing means it's included in the annual indemnity, but it's just different from the other directors' compensation, and I think maybe either justify it somehow or include it as part of the annual indemnity. That would be probably the only issue I have on this one.
Thank you. Director Elliott.
Thank you, Mr. Chairman. Just to remind Director Walsh that during the 1980s, we were paying 28% of the mortgages that we were doing. And if you don't think that was hard when you had a young family, so I don't think that keeping our directors up with current policy and current availability to continue to keep ourselves going, I think that you're mistaken.
Thank you. What's the will of the board with respect to the recommendation? Moved by Director Elliott, seconded by Director Quinn. Discussion, please. Seeing none, I'll call the question. All of those in favor? Contrary minded? Let the record indicate Director Walsh, Director Rain are opposed. The motion carries. At item 2, how say you? Moved by Director Rothenberger. Oh, okay. After I get it on the table. Moved by Director Quinn. Is there a seconder? Second by Director O'Reilly. Discussion, Director Rothenberger.
Thank you, Mr. Chair. I'd like to move an amendment that the remuneration bylaw reflect no increase in per meeting remuneration, indemnities, or expenses for 2022.
Thank you. That's moved by Director Rothenberger and seconded by Director Singh. Discussion, please. Point of order, Director Singh. Excuse me, Director Singh, if I could get a seconder before the point of order. Thank you.
I'll second it.
Seconded by Director Rain. On a point of order, Director Singh.
Sorry, just relates to the last motion, Chair Christian. I think you may have missed it. And sometimes it happens. And Director Watson was actually against the last vote. So just wanted to make sure you got that on the record.
Thank you for catching that, Director Singh, and let the record indicate that Director Watson was already opposed to that. On the amendment, please, discussion. Seeing none, I'll call the question on the amendment. All of those in favor of the amendment. I have Director Rain, Director Birch Jones, Director Swan, Director Weave, Director Walsh, Director Rothenberger, Director Watson, Director Rice. Those opposed? The amendment fails. Returning to discussion on the motion. Seeing none, I'll call the question. All of those in favor? Those opposed? Let the record indicate Directors Watson, Rothenberger, Walsh, Rain are opposed. The motion carries. How say you on 3? Moved by Director Quinn, second by Director Elliott. Discussion on 3, please. Seeing none, I'll call the question on 3. All of those in favor? Those opposed? Let the record indicate Directors Watson, Walsh, Rothenberger, and Rain are opposed. The motion carries. And given that the Dow Jones is off 940 points today, maybe that recommendation of me not taking an increase, I might want to revisit, but anyway. At item 6.1, we have the audited TRHD financial statements. Chief Administrative Officer Ray.
Thank you, Chair. And Dave, you can pull that file up on the screen just so people can see. As many directors may remember, we have the audit, external auditors come and audit our financial statements every year. The Thompson Regional Hospital District financial statements have been audited by KPMG in conjunction with the audit of the TNRD statements. Okay, thanks. They came and presented at the TNRD board meeting in May. The TNRD audited financial statements. This is just the first opportunity we've had to present the financial statements for the hospital district. Very similar, there's a independent auditor's report attached. It's an unqualified report from KPMG stating that they have done, in their opinion, sufficient and appropriate audit evidence and work to come to that conclusion that there are no material errors or misunderstandings in the financial statements. Moving on, just a couple of highlights on the statement of financial position. Let's see if I can see it a little better over here. This is, in the business world, we call it a balance sheet, and it lays out our assets, liabilities, and accumulated surplus as at December 31st, 2021. And you'll see sort of overall the total financial assets, cash and investments and receivables have decreased about $30 million compared to last year. And that's really because we've been holding cash in reserves that have been being paid out to IHA for those scheduled payments that we committed to on the patient care tower. as well as paying down the long-term debt that we borrowed that funded some of those reserves. So there's a decrease in the long-term liabilities as well as that debt is being paid down, which leaves us with an overall accumulated deficit at the end of the year of just under 52 million compared to 27, almost 28 million last year. What that really reflects, that deficit number, is the amount of tax that we still need to collect in the future to pay off that debt. In a normal business balance sheet, what you would have seen is we would have borrowed money and you would have a liability on that statement. And we would have spent that money on capital assets and capitalized that. And you would see a large capital asset on that statement, which would leave us in a surplus position. But we don't actually own the assets that we're buying with that money, IHA does. So what it really shows is a deficit because those assets aren't reflected on our financial statements. It's more of a pure expense. So really I guess the short story on the deficit is it's a reflection of the amount of money we still need to tax for in the future to get back to zero to pay down that debt. And on the next page, we have the statement of operations and accumulated surplus for 2021. Basically, everything went according to plan. The budget figures are there as well. And you'll see we had just slightly less total revenue in 2021 than we had in 2020. And that's partly because as we've been making these payments and reducing the cash we have invested, we've had less an interest on the investments. The grants to Interior Health were less than they were in 2020. That's again, that scheduling of payments, primarily in that patient care tower construction. And so you see the net result, the expenses are less than they were last year. I didn't want to go through all the notes in detail, but I'm prepared to answer any questions.
Thank you. Questions for Chief Financial Officer Ray? Moved by Director Rain, second by Director O'Reilly, that we accept the 2021 unqualified audited financial statements for the Thompson Regional Hospital District. Discussion? Thank you. Director Vivian Birch-Jones.
Yes, thank you. Thanks for the report. I don't find these easy to review, and I found your comments to be really helpful, and they answered all my questions when I was looking at it. So thank you for that.
Further discussion on the motion before the board? Hearing none, I'll call the question. All of those in favor? Contrary-minded? That is carried. Thank you. Is there any new business to come before the Regional Hospital District? Director Stamer.
Thank you, Mr. Chair. When is our next board meeting?
It will be in November after the civic election. I believe it's already scheduled on the calendar, isn't it, Corporate Officer Satt?
Yes, it is. It would be after the board inaugural. I'm not quite sure on the date.
Yeah, I believe it's the first part.
The reason I'm asking, are we going to have an opportunity to be looking in more in depth in our provisional budget with the under $100,000 ask? Or is it going to be the same presentation that we've had the last years and years where they just basically tell us this is what they need?
Good question. And I put both the CFO and Interior Health on notice that that's likely not to work going forward in terms of the presentation that they have done in the past. And they're reworking that in terms of both the consultation in the community as well as the involvement of the regional district, or regional hospital district directors in that. So that has been my counsel to them going forward, bringing that up.
Thank you, Mr. Chair.
Further new business, Director Roden.
Thank you. I'd just like to mention that barring some unforeseen and dramatic reversals in Kamloops civic politics in October, this is Chair Christian's last meeting as chair of the hospital district. So on behalf of certainly the village of Ashcroft, and I think all of us here, I would like to thank you for your service to the hospital district over several years and your massively efficient running of what could otherwise be somewhat unwieldy meetings. Thank you very much. You will be missed.
Thank you very much, Director Roden. And with that, we are adjourned at 12:08.